So thanks everybody for joining us for this session. So it's the third skills building session around paradigms, frameworks and ethics. And in this one, we're focusing purely on ethics. And Dorcas and I are going to be sharing some of our experience on the opportunities and challenges that we've faced in conducting research, but also in efforts to strengthen ethical practice in conducting global health research in settings like Kenya. So we've got Frontline in the title here. It does feel a bit strange to have Frontline. It sounds like some kind of war zone or difficult situation, but it's really just to highlight that our interest here is in the conduct of research in practice in settings that are often quite challenged in terms of resources. So when thinking about ethics, many people tend to think about ethics review processes happening before research begins, being done by clever people in closed rooms, committees, etc. But really our focus is on what happens in the conduct of the research post-approval. So Dorcas and I are going to attempt a bit of a double act here. But to get us going, we wanted to start off by hearing the voices from the people conducting research in various different contexts. And so some of you may have seen this video before, but we wanted to start off with a video that Al made in relation to a study that we'll talk more about after the video. So here we go.
We are the frontline research staff. We are the people who gather data, take samples, speak with participants and their families, carry research messages through public engagement events. Some of us are senior in our research institution, some are not so senior. But what makes us similar is that we visit people's homes and sometimes we even land up sharing meals with them. Often, we are working in our own neighborhoods, in our own communities. We listen to people's stories and struggles with interest, concerns, and sometimes sadness because these are stories that we know very well. We often land up being the face of research in communities and a bridge between researchers and communities. We have a lot of knowledge to share and face many challenges. Many of the challenges we face are to do with what should we do, what are our responsibilities in the community. These are really often difficult ethical or moral problems for us.
Research is often done in places with a high burden of disease, but also where there are many other health, social, political, or environmental challenges. There may be a drought happening, water shortages, protests around a political election, or staff strikes. In Kenya, communities were facing many of these challenges during our research, including a huge national nurses strike.
Here in Mesot, along the Thai-Myanmar border, migrants who join research on malaria and pregnancy are also sometimes living in fear of being discovered if they do not have documents. The roads and bridges may be blocked or become unavailable because of flooding, making it difficult for people to get to a research site, which is also where they come to the clinic for care.
We also see so many difficult journeys. Frontline staff also often have to cross the river in high waters during rainy season.
So the biggest ethical challenges facing the frontline staff are around wanting to help people directly, when research results may not happen quickly and the benefits may not come for many years. Sometimes I wonder why we are gathering data when what I want to do is to help people directly by providing care or medicine, something that is needed today. I realize it is important to develop better health interventions, but then I wish we could do more now. We need more support in responding to ethical challenges in our day-to-day research in our context.
Something that often struck me in my interactions with families in a very low-income area of Nairobi was how much young mothers went through to try to get their babies treated or to keep them well and restore their health. So they would try to access money, which was often not easy. They would seek advice from various networks on what to do, and this included their in-laws, parents, their neighbors, friends, sometimes negotiating with their own spouses. And all of this was happening in what were very often difficult living environments.
Here in South Africa, HIV has been a serious health burden, and so it remains a major research focus. But there are so many other health and social problems that we see people struggling with. Despite the challenges communities face, they show strength and are resilient. It is important not to label people as vulnerable or use stereotypes, because this can mask their unique needs and inadvertently exclude them from research that could benefit them. For example, labeling adolescents as vulnerable to HIV may stigmatize them and hinder participation in HIV research. We also see examples of young people's agency. For instance, they portray themselves as proactive and being agents of change in the community whilst managing the HIV disease. So their inclusion in research is important to inform context-relevant research and interventions which support their agency.
It is incredible to see how families and women will work so hard to provide for their family and make difficult journeys to seek care and to participate in research. People sometimes think that young people or women do not have power to make choices in their lives, but they do. There was a young girl, she was 16, and she joined a study because she said she wanted to gain more knowledge, she wanted to learn more.
So our question is, how can we work together with communities to make sure research priorities align with what matters most to the community? As frontline researchers, we offer a valuable perspective and bridge to understanding people's needs within research and beyond in their day-to-day struggles. But we also struggle in knowing how best to respond to the many dilemmas of care that we encounter in our work, and we need more support.
We hope that by raising our voices, research leaders, institutions, and funders will hear us, and we can work together to ensure that research remains a tool for improving lives for everyone.
So we hope that video in many ways speaks for itself, but we'll come back to some of the issues that are highlighted there throughout the rest of this session. So what Dorcas and I are hoping to do, rather ambitiously, is to cover 3 interrelated areas in the centre of this slide here. So we're interested in understanding the ethical dilemmas that are faced by frontline staff as they conduct research. We're interested in the support processes that can be introduced for these staff in handling those dilemmas and issues, and in strengthening public and community engagement more widely. All of these issues are inevitably shaped by the study, what kind of design it has, the setup of the study, in which context, which institution it's being conducted, the history, the policies and procedures of that institution, and many times across several institutions in collaborative research. And all of these issues in turn are shaped by power dynamics and inequities in the whole infrastructure of global health research. So we hope to touch on many of these areas over the next 50 minutes or so, hour or so. And what we're going to do is draw quite heavily on our research and experience at the Kamuya Wellcome Trust Research Programme. Many of you might be familiar with this programme. It's a large multidisciplinary programme with initially 15 staff in the late or early 1990s, and now more than 750 staff, the majority of whom are Kenyan, at all levels of the institution. There are many international collaborations that are involved with the Kamuya Wellcome programme, and so although much of the research is conducted in Kenya, there's research that the Kamuya Wellcome Trust programme is leading all over the world. We're also going to draw heavily on two networks in this presentation: the Global Health Bioethics Network, which is a network of community engagement staff, researchers of different types, ethicists, social scientists working in Malawi, South Africa, Kenya, Vietnam, and Thailand. We're also going to draw heavily on the experiences of a collaborative research programme, Wellcome Trust funded, aimed at understanding and addressing researchers' responsibilities in the context of vulnerability. And this collaborative programme was basically conducting case study work with 6 different research case studies in Thailand, in Kenya, and in South Africa, actually. So one of the outputs of that research was the video that you've just seen. And across all of that work of REACH, what we found is that frontline staff play, and this was highlighted in that video, play really important roles and very diverse roles in the conduct of research. And in the conduct of doing that research, they're interacting with stakeholders, with participants who are facing many different types of vulnerability, and they're layered on top of each other. So in that grey box there, we can see the different types of vulnerability that were being described in the video that we've just seen. We also see that these stakeholders and participants also have agency, the ability to make decisions and to act. But that agency is very much constrained by those vulnerability contexts. So what happens with research is that researchers are and community members are encountering the interplay of vulnerability and agency and impacting on that vulnerability and agency throughout the research experience. So the research plays a role in the vulnerability and agency that participants face. And the frontline staff, in encountering these populations, face numerous ethics dilemmas and inadequate support in handling these dilemmas often. So across the REACH programme, what we saw was some important justice concerns. The first one is that it's really important to conduct well-designed research that involves and that targets vulnerable populations. Too often there isn't enough research that targets these vulnerable populations because of the concerns of working with these groups. But it's really important that their lives are understood, their experiences and their priorities. If not, it's not possible to build interventions, to identify approaches that can build on the resilience and to try to make transformation to their lives and to undo and challenge disadvantage, which is often systemic. But we have to be really careful in conducting that research that we're not unintentionally adding to the burdens, adding to that to those sets of vulnerabilities in our research processes and the procedures that we go through. We also have to make sure that their agency is recognised, that ability to act and make decisions is recognised, protected and promoted. And throughout that, we have to really make sure that there's greater recognition and support of frontline staff. We've got to have processes in place to be able to hear what the concerns are that are being faced and to be able to respond to their voices, to the issues and concerns that they're raising. And of course, that's something that happens over the course of the conduct of research, but we also can't ignore basic issues about frontline staff in relation to, for example, levels of pay, career structure, and other forms of recognition for the roles that they play. So we'll come back to the post-approval processes in more detail, but we just wanted to make a note that clearly guidelines and pre-study approval processes are absolutely critical to the conduct of research post-approval. And guidance, there is just so much out there that it can be difficult to know where to start. But for research that's being conducted, health research in low and middle income countries, we've found that this particular framework by Manuel et al. Can be really helpful. It's a framework that brings together many other sets of guidance into a series of principles and benchmarks against which to be able to measure those principles. So we're not going to spend time on this today because we wanted to focus on the post-approval process, which this can also inform. But just to say that if you're interested in looking at this, we recommend this, this paper and the ideas shared in it. It's familiar to many of the committees who review our work. And many of the ideas are not unique to a particular type of research, but quite generalizable. But there are, of course, still challenges with it in terms of the benchmarks. Even though they're quite detailed, you can still ask, how on earth do you do that in the field, really? And there are challenges about which particular principles to emphasize and how you balance against those. The governance of health policy and systems research is more underdeveloped and contested. And I mention this because many of us here might be conducting different forms of health policy and systems research. And there's a concern that there can be quite different experiences for these types of research and implications for practice from biomedical research. And this is especially the case where the distinction between research and practice, which is so key to biomedical research guidance, is sometimes blurred in health policy and systems research and sometimes completely collapsed. And so this can have very different implications, for example, for informed consent and how that's prioritized and considered and how it's balanced against public gain, and also very big differences in terms of ownership of data and data sharing. There is an increasing amount of guidance available on this. So if anybody's interested in more guidance on different types of HPSR, please do get in touch. And one type of HPSR, which is very diverse in itself, is implementation research. And there is some TDR guidance out there on ethical considerations in implementation research that I think would also be a useful complement to the paper that I've just shared for those of you who are interested. And this divides some of the ethical considerations in implementation research into 3 different phases, highlighting issues that might need particular emphasis and prioritization at the different phases. Obviously, all of these things need consideration at all stages, but it's just useful to see where different particular ethical considerations might kick in. So as I said, we didn't want to go through those in detail at the moment, but just to highlight that those that guidance, the development of protocols, the review of those protocols is really key and definitely an important part of ethics in practice. But we'd rather focus instead on the implementation of guidance, which we know can be very challenging. And we also wanted to highlight that there's really little guidance on handling of ethical issues as they arise post-approval. And we wanted to share some of the experience and research that we've conducted around 2 important elements of implementing ethical principles. And there are many different things that we could have focused on, for instance, benefit sharing, but we're just going to focus on community engagement and this support to frontline staff. And we're going to focus on institutional policy and practice at the Can We Welcome Trust programme in Kenya. We first shared some work around this area in 2002 based on studies in the late 90s, which is basically trying to understand community and research institution interactions. And it was quite scary to have to give a presentation to Wellcome Trust, who is a big funder of research at the Khemri Wellcome programme at the time, to say that consent processes didn't actually seem to be working very well as they were intended to work. And that the institution was primarily not understood as a research institution. Instead, people talked very positively about what a great quality hospital it was, or some kind of aid organisation. And there were also a huge range of rumours, concerns and questions that were being asked about the research programme, including rumours around devil worshipping and blood, blood being taken and given to others, etc. And so this work highlighted a huge range of issues in relation to communication, also related to differences in resources between the health system and the research institution, levels of resources, but also what resources are allowed to be used for and how they can be used in the field. And we highlighted that a really key issue was this role of field workers or frontline staff, whose role is often under-recognised in working at that interface, juggling the needs of different players on the research side, on the community side, having to continuously make decisions about how to act in certain situations, and essentially acting as cultural brokers between those very different worlds of research and communities. And also they come from community members, many frontline staff, and share a lot of their views and concerns. So this work, we already had, of course, community engagement plans in place and field worker training, but it contributed to more institution-wide initiation of support and intervention areas in these topics. And Vicky Marsh and Francis Combe here were really key in instigating that work. And this was the point at which we were delighted to employ Dorcas to help us evolve that community engagement plan, which was designed together with community members and designed specifically as action research. So constantly learning from our work and changing it as we go along. And that's something that we've continued to do to date. So I'm handing over to Dorcas now to talk a bit more about the community engagement and fieldwork support processes at the programme.
Thank you, Sassy, for a very nice introduction into this. So what I outlined the community engagement work that we've been doing, and we set it up as an action research, which means opportunities for learning as engagement work is ongoing. We set up with some goals, broad goals, if you'd call it that, broad goals that we wanted to achieve through our engagement work. And one of it is to build mutual understanding and appropriate levels of trust and respect between our institution and the communities where we are conducting research, where we are interacting with those communities. The other one was to enhance the conduct of research and of the activities that we are undertaking as an institution. And the final one is to improve dissemination of findings to support policy uptake. Now, these goals have been evolving as time. These are the current goals that we have, but the initial goals obviously have changed as our engagement work has changed. Our research work in the program is across diverse settings and across diverse contexts. So we have to pay attention to the socioeconomic context in which research is taking place, the political, institutional, and the research differences that flare up wherever our researchers interact with the communities, with the stakeholders in the context that we are working. Our primary hubs, what we call hubs, where most of the research activities are housed, include the Kilifi hub, which is the headquarters of the program, and where there is a community that we've been interacting with for many years as part of surveillance, and where we draw most of our research participants. This is a community of around 280,000 residents in and around where the Kilifi County Hospital is. We also have a hub in Nairobi, which is strategically placed because of obviously wanting to interact with the policymakers and make sure that our research is relevant to healthcare in this context in Kenya, as well as feeding evidence to policymakers and feeding into the translation of policy to practice, or evidence-informed policy to practice. And then we have a hub in Mbale in Uganda, Eastern Uganda, which is also a very vibrant community, again, a different context, a different country, different political. It's also a rural community. And in addition to these, we have research across different parts of Kenya, working across the healthcare systems in Africa regionally, and as well as we have participated in multiple multi-country studies. So wherever our research is undertaken, one of the things we always carefully look at is how are we engaging the communities, the populations, the patients, whoever, how are they being engaged in their research activities? And are we meeting the goals that we set out to meet? And our engagement activities is grouped broadly into what we call public-wide engagement and more narrow, deeper interactive activities. So it's a spectrum from engagement that aims to reach wide populations, perhaps not as participatory, more towards raising public awareness about the work that we do, about the research that might be taking place, and where some of the means that we might be using include radio, include perhaps even videos that are produced and put in public spaces, including leaflets. So those kind of activities that do not allow deeper one-on-one interactions. On the other extreme, we have activities of engagement, which are quite modest in outreach, in that we'll have fewer people. It's more participative. There's deeper learning because there's interactions over time with a smaller group of people. And that opens up spaces for mutual learning, for understanding things in depth. And of course, because it's fewer people we are interacting with over a long period of time, then there's limited representation in terms of communities. And all along, sorry. Okay, so I'll move on to the next slide. So we all along, wherever we are thinking about our engagement, we are careful that we need to be careful to move beyond the seductive reign of reach, to consider the relative depth of engagement. So really paying attention to what Holman and Davis said in 2016. Next slide. Broadly, this is how we have structured our engagement. These engagement activities that are aimed at simply informing people what it is that we do as an institution, what is research, how can we co-learn, how do we respond to the broad concerns that might be coming from the community. And the study-specific engagement, which is about specific study activities. And this could be about defining what might be appropriate engagement plans, consultation on the research itself, the design, some of the sensitivities that might be arising from the community. All along, we have feedback loops. So we are learning as we're engaging, we are learning and feeding back and changing. And so our feedback, ongoing feedback from community is very important in informing our institutional policies and practice, as well as study-specific changes that need to take place. Next slide. In addition to that, we have systems that support our field workers. We have now a well-structured fieldwork training. Every staff that comes into the institution goes through an induction course where they are made aware of how we interact with the communities, what is the respectful behaviors, what are some of the social cultural issues that need to be considered in communication, how to manage different situations in the field, as well as being trained on consent processes, appropriate ways to seek consent in the homes or in the patients, issues of research ethics and community engagement. We also ensure that we are not only training our staff, but that our scientists and researchers are going out to the community and interacting with them, getting first-hand information from the community members themselves on issues that matter about their specific research and also broadly about our program. We have now, for the last over 10 years, a well-structured career progression and pathway for field workers and engagement staff that shows, so staff can be knowing how they move up the ladder, what is required, what are the systems and the processes for promotion, and so on. And that is rolled out across board. It was formed by studies that I'll talk about, and it was also formed in consultation with these cadres of staff. Next slide. So that's part of what I present is part of our practice towards engagement and frontline staff. But also in addition, we've been conducting research that are informing on these issues. And for example, one of the studies was my PhD, which was looking at ethical dilemmas for community-based frontline research staff. And I was embedding this work on what I would call community-based studies, and which were quite different. Many issues did come up, which are fed into the policy, institutions, and practice that I've talked about. But one that really stood out is this issue that are called silent refusals. And this is where field workers or frontline staff would encounter a situation where a participant says they are willing to participate in research. They would even sign up the consent form, perhaps participate in the first research activity. But thereafter, they would often dodge or say they are busy or give all kinds of reasons. And when we approach them, they would say that they still want to participate. And in fact, I faced it myself in my qualitative research, where I would see this genuine willingness to want to participate. But when it comes to actual participation, then people are not really participating. And we wanted to find out, why does this arise? And there are many reasons that I've written this. There are many reasons that were coming up. But also what became very clear, there's a lot of power dynamics that were coming into play. The moment you go into people's home, the power is no longer on you as research staff. It's on those families, that patient, that household member. They have the power to decide how you interact with them, whether you are welcomed or not. And this was putting field workers at very vulnerable position. The other one is here in this community, understanding that saying no, outrightly no, is considered impolite. And people don't want to be impolite to people that they interact with, or to even strangers. So they would rather show a willingness to want to participate, but dodge you in another way. And the other thing that actually showed the power play is the fact that potential participants were choosing their terms of participation. They would choose which procedures they were comfortable participating in and which one they were not, while all along they were accessing the full study benefits, because those could not be withdrawn just because you've not turned up for an appointment. Then you cannot be said you've been withdrawn. So it was very interesting mapping out these power dynamics and how they were playing up. Importantly for us is whether field workers felt supported to raise these issues up with their PIs, with their coordinates, and up at the institution. And that became the point at which we started figuring out, how do we make sure the voices of the frontline staff are heard, are more central in how the organization itself responds and how we do our business. Next slide. The other studies that we've been looking engagement and how it works in practice. And these are some of the papers that we have talked about, including what might be fair benefits in research and how community voices can inform our institution on what is fair benefits in the context where we are doing our research, looking at data sharing, which is a big area, and including voices of communities on data sharing policies and practices, looking at some of the controlled malaria vaccine trials. Currently, my work is looking at biobanking and bringing community voices into the center of it. And this not only informs us on community engagement itself, but also the policies that we need to make sure that they're in place, in taking account of what the community concerns are and how we can take account of those. Next slide. So moving forward, how have we taken this, again, going back to the research proposal, some of the mechanisms in which we are ensuring that these voices are heard and strengthened is in each research proposal. Now we have elements where there's specific sections on community engagement plans, where each PI must outline which communities, how they are going to engage, and if your protocol is not going to engage communities, then justify why you're not going to engage communities. All the protocols are reviewed by a community engagement team. We have a very vibrant and well-experienced community engagement team here in the program, and this work has been possible because we are able to work with such a team. We have also, like I said, made sure that there is supportive training for all the field workers right at the point at which they enter in the institution, as well as for every time that they are involved in new studies and the refresher courses that are organized. And importantly, for all research proposals, there are specific mechanisms. If the research involves a community engagement element, there's a team, an advisory team that is immediately set up involving field workers, a fieldwork representative from that research, the community engagement representative staff, as well as a social science researcher and the PI and the study coordinator. And what they do is, as the study is being implemented, they sit to review how the study is being implemented, what issues are coming up. Field workers use that as a platform to raise issues that they are facing in the field and discuss how best they could be supported. Next slide. So another piece of work that we've done, of course, we've done quite some expansive work at our program, but we also wanted to learn beyond our program and what else is there. And one of those was, how can we learn from, for example, evaluation? How can we learn what others have been learning? And so together with ourselves, the Global Health Bioethics Network, we've got a cumulative experience of work on community engagement, on relational ethics, and on empirical ethics. And we wanted to draw on that experience as part of a small study that was funded by Wellcome Trust to undertake realist review. And because there are so many ways in which community engagement can be defined, we narrowed down on realist review on community engagement in malaria trials or malaria research. So that became our narrow. And within that, we pulled together people who are experts on this field. Some of you might know Jim Lavery, who has been involved a lot in engagement and a lot in evaluating engagement. And one of his previous systematic review on community engagement found over 98,000 papers, which they reviewed to see what those papers say about engagement. What was clear from their systematic review, one of the things they highlighted is that there's insufficient conceptual architecture to pare down logically how community engagement transforms or what it purposes to do. And we brought on board realist review experts, Jeff Wong, and also Robin Vincent, who was the expert, who is an expert on complexity sensitive evaluation. So that team has undertaken a systematic review on community engagement. And what became very clear is that we need to take relationships really seriously. We have published this work in a Wellcome Trust paper. We have two policy briefs, that one meant for practitioners and the other one for funders of research. And these are up. Please take time to have a look at them. And we have also published, as part of our dissemination, we have also, next slide. We have also made a video which would like you to listen.
In recent years, there's been an expansion of community engagement in health research as its benefits become more widely seen and understood. Community engagement is also known as community participation or public and patient involvement, and it is often understood as a range of activities that it encompasses, such as community meetings, setting up advisory boards, or involving local stakeholders in the design of interventions. However, what community engagement is and how it works in practice is far more complex than it might first appear. A review of published papers on community engagement in malaria research trials in low and middle income countries highlights its role in enabling the development of precarious working relationships between researchers and local stakeholders. Rather than any specific engagement activities, It is these relationships that lead to greater acceptance and participation in the research by stakeholders, even though their motivations differ from those of researchers. While researchers may aim to produce high quality research, in countries with under-resourced health systems, a primary motivation for local stakeholders to participate in the research is the accompanying benefit of access to healthcare. So these relationships rely on the exchange of tangible benefits by both researchers and participants and are built and maintained over time by respectful and considerate interactions. There are also wider contextual factors that, while not always visible, are powerful in shaping relationships. For example, behind the interactions can be important differences, whereby senior researchers who are employed by universities or research institutions are in a position of relative wealth and power compared to many local stakeholders. In settings with high levels of poverty, the exchange of healthcare for research participation may leave people little choice but to enroll in the research, despite any concerns or misgivings, sometimes called structural coercion. The fact that high-income countries fund and control much of global health research can also undermine relationships, as local stakeholders may have less sense of control over the research. This may contribute to research not reflecting local priorities. Overall, the findings suggest that while the development of working relationships between researchers and local stakeholders helps to get research done, these relationships may rest on ethically problematic aspects of the way much global health research is typically carried out. If this is not acknowledged and challenged, there is a risk that community engagement entrenches rather than changes existing inequalities. To address these ethical challenges, researchers and funders must pay greater attention to the relational dynamics of engagement and consider wider contexts that influence these relationships. More structured support of frontline research staff by research institutions would help them navigate these relationships, but the wider context also needs to be addressed. Recognizing that access to healthcare is a primary motivation for research participation in some contexts suggests a need to consider how the infrastructure of health research could proactively support health systems in these settings. Relationships built through community engagement should complement and feed into engagement with health policymakers and managers to expand local ownership of health and research agendas. Ultimately, community engagement has the potential to help improve connections between health research and health systems and strengthen the ethics of research.
Thank you. So some of the recommendations, sorry, there's a bit of echo. So some of the recommendations that are coming from that reality review is to focus on building relationships, not just within a specific research, but to look at it more long-term. The other one is to plan better engagement and evaluation of community engagement, being explicit on the theory of change that the engagement aims, how engagement aims to achieve what, with what impact and how, and also paying attention to the broader ethical and political focus. And of course, health research should maximize opportunities to strengthen health services and systems. And we recognize that this is not always easy. In many of the contexts, there are many challenges. One of the ways in which this can be enhanced is through promoting co-designing and consultation with key stakeholders, including healthcare workers and frontline staff. And of course, institutional support for frontline research and engagement staff is really key, and program-wide engagement, as well as specific study engagement. So those are some of the take-home messages from that review that we got. Handing over to Sassy.
Thanks so much, Dorcas. And in the final leg of this double act now, and wanting to return back to institutional support for frontline staff. So that last point that Dorcas ended on, we've already highlighted that we can't really ignore and mustn't ignore those basic issues that frontline staff face in terms of pay and structure and so on. But critically, it's also about dealing with day-to-day ethics dilemmas as they arise. And so I just wanted to highlight some of the work that we did as part of REACH. I introduced REACH earlier, that's where the video came from. And one of the case studies from REACH was CHAIN. This is an observational cohort study. It was conducted in 9 hospital sites in different LMICs, including 3 in Kenya. And the idea of this cohort was to characterize the biomedical and social risk factors for high levels of mortality post-discharge from hospital. And the aim of this was to be able to identify targeted interventions that would reduce poor outcomes. So as part of this cohort work, qualitative in-depth work was conducted in 4 sites, 2 in Kenya and 2 in Bangladesh. And this qualitative work included collecting stories from family members about their whole treatment-seeking journey before, during, and post-hospital discharge, and interviews with researchers and with hospital staff on their experiences of being involved in this study. And what we have is really rich and moving stories from 64 different families across those different sites. And also lots of experience of interacting with and interviewing frontline research staff. It's really important with a study like this to highlight that there was very careful attention to ethical issues conducting the study and as part of the entire approval processes, of course. In Kenya, there was the advantage for this research that all KEMRI Wellcome Trust studies have, and that's being able to layer on top of the extensive community engagement work that Dorcas has already shared, the coordination across studies and the institutional policies around consent, compensation, etc. And in the Kilifi site, there's support to all there's clinical care support, for all children admitted in the hospital, regardless of their participation in studies. On the chain design specifically, it was agreed by many committees in many countries that there was an ethical need for a study like this because of the poor outcomes, despite adherence to WHO guidance. And there was included within that design very carefully considered and continuously reviewed referral and auxiliary care plans. And there was collaboration built into the design between clinical and social science teams with regular feedback of what was being learnt and thinking about how to deal with it. And what we learned over the course of that research is that the frontline staff in interacting with families with the types of vulnerabilities that I talked about earlier faced many types of dilemmas and challenges, and they could see these in the participants that they were interacting with. So just in those bubbles at the bottom there are some examples, and to highlight a few. Clinical staff felt it was difficult to observe patients and family members being referred to other services that they knew were of poor quality or would be difficult to afford. They were encountering challenges where there were slightly different studies happening in a similar environment with very slightly different compensation levels, only 20 pence difference between different studies, or for example, a banana. But this was causing a lot of questions and irritations among community members who would confront staff with this. The one that I will never forget is the clinical researcher who was having to ask about nutrition in the household of a mother for her children, and she just looked him in the eyes and just said nothing, and tears just came down her face when she was asked about what food there was in the home. And that clinician researcher just said, I had no idea what I was supposed to do. So there are many of these types of dilemmas that were being faced, and the frontline staff were just not knowing what to do. Where should I intervene? Where does my responsibility end? And worrying about, if I do intervene, what kind of impact might this have on others in my research team, on other participants, fairness between them, and other studies. What we found was that quite often frontline staff were not wanting to raise these issues with their seniors. They were worried that they might be thought of as not being particularly competent if they did that. They worried that they should already know the answers, or that it would be seen to be bothering very busy senior staff. So we established slowly a system to be able to raise these issues across team members. These sessions that we set up were basically safe spaces to talk about the dilemmas faced, and to think about the different options of action, and to agree them as a team. And the way that these sessions worked, they were very different to the very busy kind of team meetings where people talked about how many people had been recruited and what were the problems happening with recruitment rates and so on. Here, we would take each issue and that people wanted to discuss, and we would talk about what happened, what response was made, how did they feel about the response, were there any alternatives that they considered, and the whole group would then discuss the issue. And in that discussion, we'd be thinking about those things at the bottom of this slide. So how urgent or serious is the issue? Is somebody going to be hurt by it in the short term, in the longer term? How related is the issue to the research? Is it being caused by the research or simply revealed by the research? So the hunger issue that and the food in the household earlier was revealed by the research, not caused by it. Or is it a background issue that is there in the background for everybody? How much capacity is there for the person who's facing the issue to be helped? And what about for the person acting to implement something to be harmed in that action? And who really is the best person to help? Is it really the researcher? And what are the implications of doing any kind of action for the study, for the institution, and for others? And so in this hexagon here, what we landed up doing was for each issue thinking about what might be done. And in that A box there were many issues where nothing specific could be done, but we felt a relief in having had the issue at least shared and aired and recognized by others. Sometimes directly underneath there, the issue and the discussion of it led to an immediate agreement in the group on how things could be better handled as a team or handled differently as a team. Sometimes going up to C, that meant that we had to change elements of the study benefits, the auxiliary care, or the consent processes, how they were being administered. So a team decision was required that might change some of the materials, the SOPs, for instance, around the study. Some issues were fed up to the institutional policy level to change some of those policies that Dorcas was highlighting in her slides earlier on. And we sometimes needed to consult with and try to change the policy at HR, human resources level. We did also prepare to have discussions at national ethics review level, but that actually wasn't required for this study. And in thinking about these issues and our actions, we were always worrying about the unintended consequences of any action for the participants, the families, for health and social services and undermining them in the short or long term, for our own colleagues, and for, importantly, the science and for learning, because there was an agreed reason, ethical reason for doing the research in the first place and for needing to do it at a high quality. So we've published our experience around this approach and some of the opportunities there that that we faced or that we enjoyed as a result of doing this, psychological relief that many of us faced in the conduct of our research, recognition of each other's experiences, and the auxiliary care and benefit sharing policies, which can seem a bit sort of alien or intangible, were really brought to life in some of these discussions. We really began to understand what they meant and how they might need to be changed. But it takes time. It was really important that the senior staff in the research in that particular study were fully interested in this, and they could see the value not only for the ethics, but actually for the science of conducting that work, because many of the issues were also scientific. And a major challenge is that there were many of these emotional issues that were unsolvable. And so one's left with this challenge of where does responsibility end in the face of structural injustice? And just in terms of thinking about that approach and the studies that I'm currently involved in and that maybe you or others are involved in, we just think it's really helpful to, as a starting point, begin to think about what are the moral and ethical challenges that you're likely to expect or already expecting in the conduct of your research. Maybe thinking about these in relation to the design, to consent and understanding of what the research is about by different people, building those and maintaining those incredibly important relationships for conducting good science and for respectful interactions, and how to manage requests and expectations when they come from different people. And these issues might be faced very differently in homes, in facilities, and in other research-related interactions. The chain cohort study that I mentioned was an observational clinical study. We've faced quite different studies in an embedded health policy and quite different issues in an embedded health policy and systems study. And so just a few illustrations here of some of the dilemmas we faced there. With consent and understanding, there were dilemmas about being told all kinds of information informally, which significantly contributes to understanding the things that we were trying to study. So dilemmas around how do you use that data in a way that doesn't cause harm for people. In terms of relationships, we were doing studies where people, researchers are sometimes wearing multiple different hats, a researcher and implementer, sometimes policymaker as well, and how to maintain and be respectful in many different types of interactions and engagements. Concerns about interactions, being careful who one's seen to be aligned to. You can get involved in the politics of issues that are of interest if you're not careful. And how to handle really sensitive information, for example, what seems to be information about corruption, as an illustration. And then there's a whole range of requests that we were being asked to help with vehicles, lifts, contributions towards events, allowances, and so on. And requests for scientific information on things that weren't necessarily our priority at that time. And we faced dilemmas in terms of where and when to help, where to draw the line, and recognizing that we weren't able to introduce things that were sustainable in the long term. And so thinking about the implications of acting for that long term. And of course, anything that's done is opportunity costs in terms of time, money, and energy that might be spent on other elements of prioritized research. So having a discussion recently about this within our group, we were talking about suggestions in advance of research being, and revisiting this throughout research, being to develop shared responses to expected questions and issues across teams. So what is going to be said and what might be done, thinking about those issues as much as possible in advance and agreeing what might be done, what's appropriate, where the limits are. in terms of working in places where there's more than one research activity happening, being really careful to coordinate activities to ensure that there isn't overburdening of staff. So each particular research activity can be meticulously planned and support processes put in place. But once you add different studies together into one place, it's actually unfair or inappropriate on the facilities or the individuals or the communities involved. We also just think it's really helpful to have agreed points and ways of discussing emerging issues as they arise and how to handle them, because you can't predict everything. And also making sure that as part of thinking about ways of responding, it might be that it's about contributing to the broader feedback processes that will be built into research anyway. So that's feeding back what you're learning to research participants and stakeholders of different forms. So that's about what the research, where the research is, and what's being learned from that research. And that kind of feedback can be really helpful at clarifying what the research is about, clarifying about how individual confidentiality will be protected. It can show that there isn't fault finding of individuals or trying to just highlight problems, but it can be helpful to really highlight some of the positive things that are being seen in those processes as well. But we still come back to this situation of the limits to engagement and frontline support in terms of being unable to solve really historical background injustices and inequities for participants and communities. And we're left with the question of how research ethics can engage with deeper political, structural and health system drivers of ethical challenges. And so I think over many years of working in these areas, Dorcas and I, partly because of these ongoing dilemmas and concerns, are amongst a team that have come together to exchange ideas on decolonization and global health research. And this is bringing together colleagues from feminist research, from health policy and systems research, and from ethics, empirical and philosophical, to think through what are the different types of justice concerns that we face, how might we confront injustices more directly and responsibly in our various different roles in the global health infrastructure and architecture, whether in the global north, global south, whether at the front line, or we're reviewing papers on ethics or on global health more generally. So it's nice to have an editor on a journal in amongst the core team. So that's just a rather large and sweeping overview of various different areas, and special acknowledgements to all of the people involved in these various studies here. So thank you very much.